that the patella is in place right now, and then it's easily luxated out and back in. And so that's a grade 3 patella luxation. So it spontaneous, actually probably a 2 to 3. It spontaneously luxates. Actually, it's out right now, and it's staying out. And even on extension, it's not going back in. So now I can pop it back in. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So we have here a the patella and the tibial crest that are about that far apart, and those are going to be the central third of our incision. So we'll go a third up, middle third, and a third down. Hold on to that. And then we're going to do a parapatellar incision, which is right next to the patella. Can we get cautery plugged in, please? In suction. Sorry, guys. And the middle one, yeah, I think that one works better. Thank you. Hi, Rick from Townsville. All right, so middle third can probably come up a little bit higher on the quality of the video and of the audio, because I'm trying some new things. I have reduced the resolution. Yeah, he's going home probably about 4 o'clock. Yeah. Can't remember what I was going to say. Oh, comment on the quality of the audio and video. Because we are trying some new settings. I've lowered that. You'd think that in this day and age, that internet speed in a metropolitan area would not be a problem. I think Australia has some of the slowest internet of the developed world. All right. So now I'm just making a stab incision through the, and we definitely want to explore the joint for 2 reasons. One is to look at the cruciate ligament, because, again, if you have a dog that has a chronic patella luxation and an acute onset of lameness, it's often not because of the patella luxation. It's often because of a The other thing that we want to do is look at the depth of the trochlear groove. In the trochlear groove, but there's been some more recent research that suggests that if you don't deepen the groove, you have a higher risk of relaxation. Where did I put my scissors? Just throwing things around as usual. Very aggressive surgeon I am. So now I'm splitting the joint capsule here. There's always a little bleeder up there proximal. No, it's pretty normal. Capsule, and I think it is. So the next thing we're going to do is luxate of the patella. Now there's an interesting thing in this dog that we can see is that we have some eburnation of the medial trochlear ridge. So if you look right here, there's some eburnation, full thickness, where the patella is riding back and forth over. The other thing that I notice is that the lateral trochlear ridge is more. There's a question about whether I'm based in Singapore. I am not. I just did a locum there for about 3 weeks last year, which I loved. Okay, so now we're just going to use our Sen retractor to look at the cruciate ligament, and I don't know that you're going to be able to see anything. Okay, so the cruciate ligament, we'll bend that over. Right in there is absolutely perfect. Okay, so looking beautiful. Now, I do believe that this trochlear groove is shallow, and so I am going to do a trochleoplasty. I had a question yesterday about a block trochleoplasty, and I had said that I usually do wedges, but just to show you what a block looks like, I'll go ahead and do that instead. Can I get an osteotome and a mallet, please? Did we get them open already? No. So small, like a thin osteotome and a mallet. I'll wait to make sure that I've got the right osteotome before I commit to doing the block trochleoplasty. Basically what I'm going to do is I'm going to do 2 vertical lines here, and then just come underneath with a osteotome or a chisel to elevate that that trochlear groove, and then I'm going to come back through with the chisel again. That one. Come through with the osteotome again and deepen it a little bit more. And there's a question I can see, something about the recovery plan for MPL, but the question has moved off the end of the chat. And so I assume you're asking about physical therapy and stuff like that. So we usually allow a moderate amount of activity. Can we get saline, please? Moderate amount of activity pretty much straight after surgery, which means that they're allowed to go for walks for about 5 to 10 minutes a few times a day, but always on a leash, so no off-leash activity. That's going to be for about 6 weeks. Physiotherapy. Yep. And then we'll recheck radiographs at about 6 weeks. All right, so I'm making 2 vertical cuts. Actually, I'll score it with a scalpel blade, try to go through the cartilage here. So there's one. There's the other. Okay. So I made 2 vertical cuts in the cartilage. Can you guys see those? All right. Let's see if I can zoom in a little bit. Okay, so now you can see the cuts that I made. And now I'm just going to come in from here. And that osteotome is almost exactly the right width here. I just have to make sure that I don't go too deep and split the distal femur. That's splintering a little bit. Let's come up from the other end. See, it's just peeling off the cartilage rather than see, it's splintered. What I've done is inadvertently just peeled that cartilage off. So I've got a little shaving of cartilage, and that's not going to be a major problem. Okay, but I am going to, it's not exactly what I wanted to do. Problem is, I don't think this scalpel is terribly sharp. This is not one of the ones that I sharpened myself. So that's a good lesson, is to make sure that your scalpel is really sharp so it bites into the bone. Okay, so you can see that that's quite a bit deeper. Just do a little flush here. And I'll replace that cartilage. Can I get some 2O PDS, please? So the issue there was that the osteotome not being super sharp, it kind of glanced off the bone and just peeled the cartilage off. So the power tools that we use are Synthes. So here's my cartilage, putting that back in. And it really is just a sliver of cartilage here, so that's not what I intended. And there has been a procedure described where people just go in with a rongeur and take off the articular cartilage anyway, so I don't think it's a big problem. That's my cartilage laid back down there. And then we're going to pop it back in, reduce it. And I'm going to do some imbricating sutures. And so yesterday I did a vest over pants. Today, just to add a little variety, I'm going to do just a wedge, or sorry, a crescent resection. So I'll show you the alternative way to do it rather than a vest over pants. So what we do with that is we come through and just take out a sliver of the fiber cartilage and fascia lata. And then I'm just going to do a cruciate pattern. So grabbing fascia lata, joint capsule, fascia lata. And I'm closing it at this point rather than later, because I don't want to lose my little sliver of cartilage that I've put back in my groove. I am going to sharpen that osteotome. I have a diamond burr sharpening stone set. It's basically just diamond dust that's impregnated in stainless steel. And that is a really, really good way to sharpen your instruments. Question about taking cartilages, cartilage from another site and using it. You probably could. It's not going to be as smooth. And Rick, don't feel bad or guilty about asking me about the block. That's 100% on me. And for not having the sharpest instrument. And again, it is going to be fine because we have lined it with a nice layer of cartilage. It's a nice deep groove, and so we have the patella pushing that cartilage down to help it heal. And again, even if there was no cartilage there, it still would fill in with fibrocartilage. And honestly, in one study, just deepening the groove, doing a trochleoplasty, without doing a tibial crest transposition is enough. For patella luxations, but I just feel like if there's an alignment problem that's causing this, then we should fix the alignment problem. So I'll just have a good look at where the tibial crest is. My tendency is to say that I would do a tibial crest transposition. All right, so get rid of my Gelpy. I'm just going to look at the alignment here. And the tibial crest is a little bit medial. It's solidly in place. You can see here that it is a little bit medial relative to the patella. So my tendency is to say that I will go ahead and do a tibial crest transposition. It's very easy and quick. All right, so let's hold that up like this. And I'm just using my cautery to very carefully dissect that cranial tibial fascia off the tibial crest. And then I'm going to take a Homan, and reflect that cranial tibial muscle back. And I'll use a freer elevator to peel all that off. Just pull that back like that. And then I need to protect my patella tendon. Back a little bit farther here. And Rick is asking whether the decision to do a trochleoplasty would depend on the grade of the patella luxation. I imagine that that's probably the case to some degree. Taking a nice big chunk. Can I get a pointed reduction forceps, please? And then I've left the distal end intact. And so when I break this over, you hear that little pop. that means that my periosteum is going to be intact. Okay, so nice big tibial crest. You can see that how big that is right let's see. Yeah, perfect. You can see how big my tibial crest is. All right, let's just move the camera down a little bit. So you can see what's happening there. All right, so that's my tibial crest right there. So nice big piece of tibial crest. And then I'm going to use my saw to make a little bed for the tibial crest in its new position. Might reflect it. Maybe with the Gelpy, take out that. Okay, so then just cut out a bit of that. Okay. Okay, so I've just made a little bed there. And then I'm going to use my pointed reduction forceps to reduce around the back of the fibella. Levering that up so that I can. Okay, so now closed. Just see how much bone, medullary bone I can see from the original site of attachment. Release that. Okay, it's definitely come across. And it is kind of you move it. All right, and a dog of this size, how much does she weigh? He weigh? 15. So I'm going to use 045 pins. Yesterday I used 032. Let's just see how these look. That's about right there. I feel like it hasn't cut. I would like it slid over, but it hasn't rotated around. Like it slid over, but it hasn't rotated around. There we go. You always want to have another pin that's the same size. Okay. We'll use our suction. Let's just remove that and just make sure that it's solidly in place. I use my suction tip, for those of you that didn't watch yesterday, use my suction tip to bend the pin over. Thank you. I'd like to see if I can feel the pins back there. Just going to put one more pin. Sure that they're exiting the caudal cortex. Thank you. Hi, Abdul from Afghanistan. Hi, Robin. All right. So happy with that. Good range of motion. That might twist this pin around just a little bit so it's not sticking out as much into the so I just feel like that feels a bit loose to me. Just going to make sure when I close this that I'm bringing a lot of soft tissue up over those pins. Farther proximal. To really try to protect those pins from creating a seroma, from causing pressure. Can you get them to please pre-med the next one? Pre-med the next case. Okay, no problem. That's right. And we have done a femoral and sciatic nerve block on this dog for post-op pain relief. Using bupivacaine. Sub-Q fat. We get some more 2O PDS. So now I'm just going to close the genicular fascia. So a question about post-op complications. Good question. So the most common one we see is a seroma over the pin tips, which I don't think is a really major one, but it does mean that we do have to take those pins out when we've had healing of the osteotomy. About 5% of dogs are going to have recurrence of the luxation, either medially, same way as it was pre-op, or some will go laterally if you pull everything too tight. So you imbricate them too much, or you transpose the tibial crest too far. Early on in my career, I had fracture of the tibial crest. I've also seen the tibial pop off and the pins either breaking or coming loose. Don't know if I've had that happen to me. I probably have. Getting practice for 35 years, so it's possible that early on I had that happen to me. And infections are pretty rare with these guys, and that's about it. All right, I'm just going to go back and make sure I haven't missed any other questions. Can you do just a tibial crest transposition without deepening the femoral groove? You definitely can, and that's kind of how I used to do them almost exclusively, and then more recently I've started doing more of the trochlear grooves. The decision kind of is dependent on how deep the groove is, and the thought is that if you have more than 50% of the patella 50% of the patella within the groove, that's adequate. And if you don't, then you need to deepen the groove. But I have certainly done dozens and dozens of them without deepening the groove. Question, do we send home oral opioids? We do not. We usually just send them home on paracetamol and meloxicam. If you wanted opiates, we might send them home on a fentanyl patch as well. I do sharpen my osteotomes in-house. There's a question about what 5 patents I have. I have the limb-sparing endoprosthesis. I have a couple of different ones which were for correcting ligament instability of the distal, the tibiotarsal joint. I have one which was for fluid collection after laparotomy to assess for infection or peritonitis. I can't remember what the fifth one was for. Might have been a modification of the endoprosthesis. Hi, Monica from San Diego. Hi, Brazil. Hi, Elizabeth. Hi, Sudan, Townsville, and Kurt. So go ahead and wrap it up now. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you get a ding on your phone the next time we live stream.